is Bronte, and on behalf of Radiology Scholars Certificate Program at Wake Forest School of Medicine, I'm here to talk about adult brain tumors, and this is part 1 in a 2-part series. So learning objectives for this video is to be able to identify common adult brain tumors on imaging, specifically glioblastomas, oligodendrogliomas, and meningiomas. We also want to make sure that by the end of this you understand common clinical presentations of primary brain tumors and when imaging is indicated. There are many types of brain tumors. They are commonly divided into 2 categories. Those categories are tumors that are commonly occurring in adults and tumors that are more commonly occurring in children. There are more types of tumors than the ones that you see here, but these are the brain tumors that are most relevant for medical students to be able to distinguish. There will be another video about pediatric tumors, so make sure to watch out for that for a better understanding of the tumors listed on the right. And there will be a part 2 to this video that will discuss the last 3 brain tumors more commonly occurring in adults. So for this video, as previously mentioned, we will be talking about glioblastomas, oligodendrogliomas, and meningiomas, and how they present on imaging. First, I wanted to discuss common clinical presentations of patients with brain tumors. It's important to understand which symptoms make clinicians more or less worried about brain tumors based on their proven association with the mass, rather than other brain pathologies like a stroke or infection, for example. This chart demonstrates the most common presenting symptoms. This data was pulled from a research project that studied 10 years' worth of ED visits at a single institution and how the patients with brain tumors originally presented to the ED. As you can see, a focal neurologic deficit was the most common presenting symptom. This is due to an occurrence called mass effect. Essentially, as a mass takes up space in the head, it will begin to press on surrounding structures as there is a limited space inside the skull for both the brain and the growing tumor. The tumor compressing and displacing the brain makes the area of the brain that is being affected functionally irregular. This can cause neurologic deficits, from weakness to sensation deficits to nerve compression, pain, and so forth. This usually occurs over the time span of months, which is a great distinguishing feature from stroke patients, who will have similar deficits but with an onset of symptoms over minutes to hours. Altered mental status was the second most common symptom, also caused by mass effect from the tumor itself, and also swelling around the tumor. Headaches are more concerning for tumors when a patient wakes up with a headache, when they get worse with position changes, when they occur for days or weeks at a time, or when they are refractory to Advil or Tylenol. These are called alarm symptoms for headaches and are generally reasons to get head imaging. Of course, a new onset seizure is a concern for brain tumors, as well as progressive nausea, vomiting, dizziness for no other clinical reason. Now, sometimes patients will come to the ED due to a trauma, and a brain mass is incidentally found when looking for injury from the trauma. According to this study, 7.8% of the tumors they studied were originally found incidentally on trauma imaging. So some clinical pearls that I found interesting while studying this topic. Approximately 30% of brain tumors are primary, whereas the other 70% are metastasis. Brain metastasis will be covered in the second video on this topic, where we will discuss this a little bit more. These next 2 bullet points explain that prognosis and treatment of brain tumors are generally variable on the type of tumor, the location of the tumor, the age and comorbidities of the patient, among other factors. However, a particular study found that the overall 5-year survival rate of patients with primary brain tumors is around 33%. Generally, treatment includes a combination of surgery, chemotherapy, and radiation therapy. This slide goes over some of the symptoms that qualify as indications for imaging as described by the American College of Radiology. These mostly include the common presenting symptoms discussed in the previous slides. A headache with some of those alarm symptoms we talked about earlier is an indication for imaging. A new neurological deficit is also an indication for imaging, which should make sense as it was found to be the most common presenting symptom for brain tumors. Altered mental status and seizure are also defined as indications for imaging. So, the first type of brain tumor we are going to be discussing today is a glioblastoma. This is the most common primary brain malignancy, and in my opinion is one of the easier to identify on imaging. It is typically located in the cerebral hemispheres and can cross the corpus callosum. In the case that it crosses the midline of the brain, it is sometimes called a butterfly glioma because it resembles the shape of a butterfly. This image on the right is an axial non-contrast head CT. For more information on how to differentiate types of images and how to develop an approach to reading different imaging modalities, keep an eye out for our videos on these topics. Glioblastomas commonly present as a heterogeneous mass on CT because there are different components of the tumor. The periphery of the tumor is isoattenuating or hyperattenuating. This is where the viable tumor cells are. Centrally, the tumor is often hypoattenuating due to central necrosis. On the left is an image from a T2 FLAIR MRI sequence, meaning a T2 weighted sequence with the CSF signal suppressed. The image on the right is from a T1 weighted sequence after contrast was administered. On MRI, glioblastomas show up as garland-like masses with enhanced margins. The margins of the tumor are described as irregular, and that's where they get this garland-like description. Glioblastomas often have a necrotic core, as previously discussed. This can be seen really well on this T1 image as the hypointense center. On the T2 FLAIR, you can see the hyperintensity of the edema that is surrounding the tumor particularly well. In summary, a brain tumor that crosses the corpus callosum with its central necrotic core is very suspicious of a glioblastoma. Lymphoma is another tumor type that may cross the corpus callosum, but it is rarely necrotic prior to treatment. The next tumor we're going to talk about is an oligodendroglioma. These tumors arise from oligodendrocytes, as the name suggests. Their typical location is in the cerebral hemispheres, and they have a predilection for the frontal lobes. This image is an axial non-contrast CT. These tumors are generally described as an ill-defined mass, meaning the borders of the tumor are a little harder to clearly delineate. They generally have coarse calcifications within the tumor that cause this hyperattenuating signal throughout. These are MRI images of the same tumor. Once again, the left image is a T2 FLAIR image, but this time in the coronal orientation, and the right image is a T1 weighted post-contrast image in the axial orientation. So on T2 FLAIR, the image will mostly be hyperintense, except for the calcified components, which are generally darker, as you can see. Like glioblastomas, these tumors are heterogeneous, as the tumor is made of different components that cause signals to attenuate differently on imaging. In summary, oligodendrogliomas are heterogeneous and have calcified components. They have a predilection for the frontal lobes, and they have unique appearances on CT and MRI. These tumors are most common in women and are usually very slow growing. Therefore, they are generally only symptomatic once they are larger. These tumors can be supratentorial, meaning along the cerebrum, or infratentorial, meaning below the tentorium cerebelli, including structures such as the cerebellum or brainstem. However, they have a predilection for the parasagittal location, which is in the dural folds along the sagittal sinus on the superior portion of the brain. On CT imaging, they can be slightly hyperattenuating to the normal brain, but they can also be isoattenuating, or the same attenuation as the rest of the brain on imaging. In this example, the tumor is slightly hyperattenuating. The tumor often has internal calcifications and adjacent hyperostosis, which means reactive thickening of the adjacent bone. Once again, we have a coronal T2 FLAIR on the left and an axial T1 weighted post-contrast MRI image on the right. On T2 FLAIR, a meningioma will generally be isoattenuating to the brain. These tumors avidly enhance and can sometimes show a spoke wheel pattern of enhancement, which is very well demonstrated by the T1 post-contrast image that kind of shows these rays of enhancement from a central point that look like spokes of a wheel on a bike. They will also sometimes have a dural tail, which is thickening of the dura in an area adjacent to the tumor that looks like a little tail off the edge of the tumor following the dura. There can sometimes be edema in the brain adjacent to meningiomas, particularly as they get larger or as they invade the brain. In summary, meningiomas can occur in many places throughout the brain, but they have a predilection for the dura, specifically the parasagittal dura. They are slow growing and generally have a better prognosis because of that. They can have some distinct characteristics on imaging, like their spoke wheel internal enhancement, calcification, adjacent hyperostosis, and dural tail. And that's it. Here are some references that I used to study this topic. Thank you so much for watching. A part 2 will be up, so make sure to watch that, and take care.